Welcome and good morning, everybody. It is so good to see you all this morning. Super excited to see you all and super excited about our presenters and presentations for today. We're going to get right with it because really 3 hours is not enough time to cover all of the information that our presenters are wanting to give to you, let alone what we want to learn. It's just not enough time. And so we're going to try to get with it. I am certain that you're going to be pleased with what we have today. And Dr. Ritchie has already established herself as credible to present. I mean, the amounts of thank yous and that was so helpful and thank you for the tools. We're not putting pressure on you, Dr. Ritchie, because you have already performed. It's already known. Once you show up like that, it's just what it is. But let me stop talking because we want to get on to it because Dr. Ritchie has a lot to share for us today. And I just pivoted here. Let me see. Uh, let's get on to the bio here. Okay, so we are so excited to have once again Dr. Jennifer Ritchie to present to us. Dr. Jennifer Ritchie is a licensed psychologist and executive director of Gateway Behavioral Health Consultants LLC and her Harmony Collective ADHD coaching. I love that name in St. Louis, Missouri. She specializes in psychological assessment for adults and children, as well as treatment of ADHD, anxiety, and mood symptoms in women. She also serves as the psychological testing director, providing training, supervision, and program development for a local nonprofit organization in St. Louis. She is seasoned in providing clinical assessment, psychoeducation evaluations, and court-ordered evaluations. She currently serves as the president for the St. Louis Psychological Association. Amazing. All right. And without further ado, we're going to hand it over to Dr. Ritchie. We thank you for being here. Thank you for joining us. And thank you for presenting for us, Dr. Ritchie.
Thank you, Toya. I am so excited to be here today, guys. This is one of my favorite topics to present on. I love talking about all things neurodivergent. So I'm super excited to be here. I'm going to start sharing my screen here with you guys in just a second. And I just want to let you know as we're going through this presentation today, please feel free to ask questions. Please feel free to put some comments in the chat and raise your hand. I absolutely love talking with people as I'm training. I hate waiting to the last minute to do questions. It feels way more fun and interactive for me if you guys are chatting, raising your hand, asking questions as we go through. So please feel free to do that. Um, like I said, this is one of my favorite topics to talk about, especially when we talk about neurodivergence in women, because it's not well understood. We're learning a lot more about it as we progress in our research. So that's what I'm going to be presenting on today. And I hope you guys find some really good and valuable information as we go through today. Um, so my goals for our time together today are to just talk to you about how ADHD and autism present in women. It presents very differently in women than in men. So it's something to, as clinicians, when you're thinking about intakes and referrals to other professionals, something to be very aware of. Um, we're going to talk about how some of the challenges that present in trying to identify these I don't want to say disorders, but these types of functioning in women, because we know a lot of this is how their brains work. And this is just kind of the way their brains are wired. Our DSM does identify them as disorders, but this is something that I'm really trying to advocate for and steer a little bit away from within the clinical community. I also really love to give people some practical tools when it comes to their clinical practice. So I'm going to provide you with both some widely available free screening measures and also some paid measures that you can use in your practice for screening for adult ADHD and autism. Some will be specific to women and some will be more generalized, and you can use them across the board for both males and females. And then we'll talk a little bit more about when to refer for a comprehensive diagnostic assessment. This can be really helpful, especially for some of your higher functioning, lower support needs women who have other co occurring mental health disorders, to make sure that they are getting the right treatment and can get the accommodations that they might need for work or any other types of services that they need. So let's go ahead and get into it, guys. Like I said, if you have any questions, please feel free to put those in the chat as we go along. I will periodically be checking that just to kind of go through and make sure that everybody's getting their questions answered. All right. So let's first off talk about why the gender differences in ADHD and autism in women, because there are a lot of gender differences. Um, so historically, um, there has been a lot of research that is primarily focused on the male presentation of ADHD and autism. There, for decades, was very little information about how these conditions presented in women. Um, it wasn't until the early 2000s when research really started to look at how these conditions presented in girls and women. So there were two really big studies in the early 2000s. The Massachusetts General Hospital study was published in 2004, and it looked at the differences between ADHD in girls and boys. Um, and it really showed that girls who have ADHD have impairments in functioning, which was huge. We really thought that ADHD didn't exist in girls, and it it didn't bother. Like if they didn't have it, so it didn't bother them. But when they really looked at the research, they showed that girls who had this had problems not just at school, but in their relationship, and also in their social emotional functioning. So this was a really big landmark study that showed that this really does impact how girls function in their day to day lives. Um, Another big name in the ADHD research is the Berkeley study. This was initially published in 2002, so right around the same time as the Massachusetts study. And it just kind of was this a similar outcome that girls with ADHD have these big impairments in functioning. Um, Research about females presentations of female presentations of autism really didn't start coming out until the early 2010s. Um, so if we're talking about the amount of time that we've been able to really think about the research and understand these conditions in women for ADHD, we're looking at about 20 years. And for autism in women, we're looking at like right around 10 to 15 years. And so we know there's a delay in when research presents this information and when it comes out in clinical trainings, and we as clinicians understand this. So this is really something that we are just getting a little bit more of a handle on as clinicians, and it starts to inform our treatment. So this is a really great topic to learn about when you think about your clinical practice. So there is a lot of under diagnosis in women for ADHD and autism. And the differences are really alarming, guys. So boys are referred 10 times more for autism assessments than girls are. Um, I'm sure over the years you've seen the rates of like 1 in 90 children have autism, 1 in 84. Like it's just kind of steadily grown. But we know that girls are diagnosed somewhere from 2 to 1 to 6 to 1 when we look at autism spectrum disorders. So girls who have higher support needs or are would be considered lower functioning in the past get diagnosed more at that 2 to 1 rate. It's a little bit more equal. But when we have higher functioning girls or higher functioning women, they are diagnosed at a 6 to 1 rate. So even though males who are higher functioning get diagnosed more often than women, there's still that like a really huge difference. Um, that Asperger's diagnosis that was previously in DSM-4 really caught a lot of those higher functioning males, but didn't always catch those higher functioning females. And the rates of referrals for ADHD assessments can range for women anywhere from 3 to 1 to 16 to 1. So I think it really depends on how the symptoms are presenting in women and the awareness of clinicians, teachers, things like that, um, for them to be able to recognize it and refer them to the appropriate type of clinician to diagnose this. And diagnosis rates range somewhere between 3 to 4 to 1. So, kind of in a similar range for autism spectrum disorders, but there's less difference in variation depending on the level of severity or the level of the support need. Um, there are multiple reasons for this underdiagnosis and misdiagnosis in women. I talked a lot about how in the research that we did not, as clinicians, know a lot about ADHD or autism and how this presented in girls and women. So we've always kind of looked at how it presents in males. And that bias has kind of stood the test of time. And we're just now starting to learn more about how this presents in women. Um, Parents and teachers also tend to underreport female symptoms compared to males. One of the reasons, and we'll talk a lot about this, is women do a lot more compensating. They tend to internalize their symptoms more than males do. So you might not have teachers or parents who are reporting these symptoms on rating scales or during interviews as much as they do for their male counterparts. And then there is, like I mentioned, the internalizing versus externalizing. There's definitely a difference in how these symptoms present. So, as a clinician, you need to be more aware of how these diagnostic criteria present in women and what they look like. They are similar, but there are some differences that you just need to be aware of. So, I want to kind of just ask a little bit of a question here. Feel free to throw this in the chat. How many of you who are at this training work with individuals who struggle with ADHD symptoms or present with these concerns, or anybody with like developmental disabilities? I'm just curious. And maybe if you're putting that in the chat as well, let me know what types of questions you have or concerns that you see presenting in your practices, in your clinics, and where you work at, so that we can talk and I can make sure that I'm giving you guys good information about what to look for and what questions you guys might have. That's always super helpful for me as I'm kind of going through my presentation to know. Um, so Denise is saying yes, she sees people in her clinic. Who else here sees people in their practice or in their clinics? And what questions do you have as we're going through this training about how this presents in females or how this presents in girls in general? Give you guys a minute or two to put that in the chat before I kind of dive into um, how autism presents in women with the diagnostic criteria. So I'm seeing a couple of people saying that like potentially they might have people referred to their clinic or this might be a concern. Um, um, this is something that I think is important to think about is like a lot of times um, women will present with chronic anxiety, chronic depression symptoms. And it's really important to kind of screen for some of these conditions because that is the way that they sometimes present or get referred for treatment. So Kristen says she's very curious about the differences in the response to ADHD medication in girls, women versus boys. Um, that's a great question. We can talk a little bit about treatment and um, how some of the hormone differences play a role in how women will present to that. I'm definitely planning on covering some of that. I am not going to talk much about medication. That's just not my area of expertise, but I will talk about how women and hormones definitely play a role in symptom presentation and treatment. All right. Um, so let's talk about how autism presents in women. And I'm going to use some of the case studies that I've done because I see this a lot in my clinic, and I think it's helpful to really talk it through and give you some specific examples of what this can look like so that you can kind of get a better understanding and really see if there's any specific cases or things that you can relate to. So, we're going to talk really about the diagnostic criteria A, and then we'll talk about the diagnostic criteria B, because those are the two big ones for autism spectrum disorders. And the first one, which I think most people are really familiar with, is the social emotional reciprocity, challenges with nonverbal communication, and then difficulty developing, maintaining, and understanding relationships. And so, one of the things that we see in girls and females is that they're better able to engage and have some type of interaction with people. It's not always great with reciprocity. Sometimes there are some challenges there, but they are much better able to do this with boys, especially at a younger age. One thing that comes up is that it becomes more difficult for them around middle school, where the demands for social interaction are much more challenging with girls. There's a lot more unspoken rules and social expectations and norms that have to be inferred. I'm not sure how many of you here, there's a lot of women here. I would guess, just based on the field, how many of you can see teens or girls that in general just struggle with social interactions as they get older because there's so much more demand with this. You can just drop that in the chat, let me know. But with girls who are autistic, they struggle to have that reciprocity and understand kind of those non-spoken rules, those that tone, those nonverbal interactions and communication that come as they get older. They are better at picking up some of those things when they're younger, when they're not as subtle or more, they're a little bit easier to pick up on, but they have trouble identifying specifically what those things mean. So, what I mean by that is they can generally pick up on the tone of things. Like somebody might not be happy, they might not be really enjoying, but they can't pick up on specifically what they're doing or why that person might not be enjoying the social interaction. Social relationships also take a lot more effort for them. So, they might report like being mentally drained and really struggling and are exhausted and needing to just come home and withdraw completely after social interactions. You might also see girls who like refuse and have a lot of anxiety or refusal behaviors as they get older um, around these things. The one thing that comes up with women a lot is camouflaging. How many of you have heard of camouflaging? If you could just throw that in the chat. I want to make sure that we're talking about some of the really common terms that come up in the neurodivergent community, because this is something when I do evaluations, I am really assessing for is how much are these women trying to camouflage or kind of hide their symptoms from everyone. Okay. So what people are saying, yes, they've heard of this, which is great. And for those of you who haven't, I'm going to explain what this is. Camouflaging is basically attempting to hide or compensate for neurodivergent traits. So I've had women who will come in and tell me they have researched where, if they have to go to a social event, they will research the place where the event is being held. They will learn about it. They might even go and scope it out as a way to compensate for their anxiety that can come up around that. They might test drive going there. They might try and write some scripts out or script in their head how they could talk to people and interact with people. They will do a lot of different things to try and camouflage how difficult it is for them to have that social interaction. So when I talk about like it takes them a lot more effort, you don't typically see this in females who have maybe just depression or anxiety. I don't even typically see this with just ADHD. This is a very distinct thing that I see of women who go and they practice these things, they run them out, they do a lot of scripting in their head and practice saying these things because they know and they're aware that they struggle with this so much. I occasionally see it with social anxiety, but the extent of it and the severity of it is pretty distinct with autistic women. Another challenge that we have with um, diagnosing this is that autistic females tend to be have more developmentally appropriate language and are better developed with like imitation and play skills when they're younger. I think I mentioned this a little bit earlier, but that's something that you might see them have appropriate language skills, but their pragmatic language, which is their social language skills, are more difficult and they have more trouble with this. So, especially for those of you who are familiar with any testing or might look at this, they might be great at reading. They might be great at being able to articulate things in non-social context. Like if they're explaining something for their work or their interests about things, they might have really good verbal skills. And if you contrast this with their social language, how well they do explaining their feelings, how well they do clearly talking and having that back and forth conversation in social interactions, that's usually very, very different from their verbal skills. And so it's really important to differentiate their verbal skills from their pragmatic language skills. And there's definitely some things that we can look at when it comes to screening and asking questions that you can consider for that. So, challenges with developing and maintaining and understanding relationships. Um, One thing that can happen is when you look at these girls or women from afar, they might not seem socially awkward. They might actually even seem socially appropriate. But if you really start to ask them questions or kind of ask the people close to them about their social relationships, there's some kind of quirky stuff that will come up. They might say, like, you know, they're really delayed or they have some really awkward stuff that they do. They don't seem to get jokes. They say stuff that's not appropriate, or you have to start to kind of dig in and ask the people that are closer with them, really ask specific questions about their relationships to the people who are around them the most, which can be hard because they don't always have people who are close to them. And so that's something that you really need to be specific about. Um, they might be able to make friends, but if you ask about their patterns of relationship, you might see that they make a friend but have trouble keeping them. So rather than being able to develop long term friendships over time, they might have a friendship and then drop off, and then a new friend and drop off, and really just have trouble maintaining friendships over long periods of time. So that's another pattern that you can see. Um, that it's hard for them to maintain those relationships. It's not necessarily that they can't make them, it's more of the maintaining for women, where sometimes boys have more of the challenges with actually developing them. Um, so I'm going to share a little bit about a woman that I did an evaluation for about a year ago. Um, she had always, from a young childhood, struggled with relationships. She had never really had close friends. Um, and that was something that her, even when I talked with her parents and with her partner, that they had mentioned, like, she doesn't have close friends. She doesn't seem to want to spend time with people. She gets really overwhelmed. She needs time to like reset, and that she doesn't really want to seem to be like around people as much as we do. And so when I talk with her, she really explained that she gets overstimulated from like sensory stuff. She doesn't know what to say. And so it causes her a lot of anxiety. She was a very smart woman and worked as a receptionist at a gym. You would think that that's maybe somebody, an autistic woman would work in a receptionist, but she would, around about every 2 hours, go out to her car and cry because she would get so overwhelmed with the interaction. And that was one of the ways that kind of like she camouflaged or she compensated, is she would regularly go out to her car and cry to let all of her intense feelings out and then go back to work. And so she had just had that job for so long. It was such her routine that she didn't know any different. Um, but she was also afraid to kind of interview for other jobs or look for positions due to her challenges with social communication. So that was something that really bothered her, but she didn't know, and she felt really stuck in that area of her life. So, any questions about criteria A before I go on to criteria B for autism spectrum disorders in women? How this might present, any questions you had maybe about cases that you've seen? I think really asking questions about kind of around middle school time, asking questions about how things were over the period of time, not just asking questions about their current relationships, is really important when you're thinking about this. And then another area to think about is how effortful these relationships are for them. Not just can they do them, but how much effort does it take and how much does it affect their mental health, with like anxiety and depression. Okay. I'm going to keep going then. No questions. Criteria B is a lot of the restrictive, repetitive behaviors, sensory issues, um, and restricted interests that you will see. And so, restrictive, repetitive behaviors, that's a lot of the stuff that we know is like stemming. So, some of the like historical common ones are like hand flapping, echolalia, where people will repeat certain phrases or certain words they hear other people say. Um, you might also have somebody who does some rocking. Like, those are some of the more pronounced and common restrictive repetitive behaviors that have commonly been associated with autism. With women, we know that these behaviors are way more subtle. They and they often camouflage these behaviors. They try to hold them back until they're in private to do these, or the stems that they do in public are less noticeable to others unless you're very trained and you're picking up on them. So I'm going to give you some examples that come up. And a lot of times these can be misdiagnosed as obsessive compulsive disorder, things like that, because they don't dig into some of the other stuff underneath it. It can also co-occur with OCD, so it's something to be aware of. Skin picking is a common one. So picking at their face, picking at sores on their body or other areas of their body, picking at their hair. And so I always ask questions about this. Are you a skin picker? Do you pick at your hair? You might see them pick at their eyebrows. They might have like one of the common things I see, guys, is that women will pick at an area that people can't see. So they might pick at one spot in their hair that if they let the rest of their hair down, no one's going to see, but they will distinctly show me like here's where I pick, and if they show you there's like a huge bald spot there or hair that's been growing back from where they will pick at their hair. And these behaviors are usually meant to self-soothe. It's something that helps them when they get overstimulated. A lot of times they'll do these in social situations to manage their overwhelm or their anxiety. Another one that I've seen happen is things that they will do inside their body or internally. So I've had women who chew on the inside of their cheeks or chew on their tongue. I've had women who will twirl their hair so it doesn't really look too bad, but they twirl it to the extent that like it starts to pull their hair out. So that's another thing to kind of ask about. Um, they might also like listen to the same music over and over. Like some people will do that, but these women do it to the extreme. Um, Watching the same shows, the same movies to like where they can repeat them word for word. So those are some things to kind of look out for when you're looking at repetitive behaviors for women. So, insistence on sameness, inflexibility, and ritualized patterns of behaviors. Girls tend to present way more rigidly, but internalize these symptoms rather than like externalizing them. So, what I mean by that is boys, if you adjust their routine or you switch things up on them, they're more likely to have a tantrum, a meltdown, engage in like some refusal behaviors that you see, can visibly see these. Somebody could observe them and watch them. Whereas women, they tend to get more anxious about them. They might get more irritable about them. Um, and they might just start to do a lot more like what ifs and trying to play out every scenario in their head, um, rather than that like outward behavior sign. So some of the ways that this can present in women is just like rigid rule following. They will have arbitrary rules that they've made up and they follow just because. And when you start to ask them about that, it's pretty clear that there's no um, logical, like external reason for this. So, what I mean is, like, I had a girl who was really into Spice Girls. That was one of her restricted interests. Um, and she had made up reasons for listening to certain songs on certain days. And she followed those rules very rigidly. She would not listen to different songs on the assigned day. And when I tried to kind of like ask her why, like, hey, how come you can't listen to Wannabe on Tuesday? She would be like, because you listen to it on Wednesday. And that was just her rule. She had made that up. It was the way it was. And she would not deviate from that rule. And so she was very rigid about following that rule. Um, if her mom or her sisters would try and play a different like song in the car for that day, she would get very upset, very irritable with them, and just insist on playing the song of the day. So that's a way that it can present. Um, For women, it can also present as like extreme perfectionism, uh, doing things to spending hours on emails, hours on reports to get like one little detail right. Um, and people don't really understand why they're spending so much time, but then they might miss other pieces of things that like they're getting those small details but missing kind of big picture or really poorly managing their time, which can create a lot of problems with time management, anxiety about not getting things done. So that's one that kind of comes up. Rigid rule following also goes with like this extreme black and white thinking that they have. They're very black and white, have trouble seeing gray. So this can come up in friendships. And so I've seen girls who will cut off friendships because somebody wronged them in their mind, that they have trouble like this person is no longer my friend. I cannot be friends with them because they broke some arbitrary rule or because they did something that means they're not a friend. And they have a really hard time going back and saying, like, oh, maybe I could be friends with that person again, or maybe I could try and work things out with them. It's very black and white. They aren't my friend anymore. I can't be friends with them. I have to find new friends. So this is something to kind of be aware of when you're, especially when you're thinking about social relationships, that there's very rigid rules or cutting people off for kind of no apparent reason. When we talk about diagnoses, this can sometimes look like borderline personality disorder, where people get cut off, doesn't seem logical. And so that's one of the common misdiagnoses that comes up for these women. For restricted interests, girls tend to have more socially appropriate interests compared to boys, but they tend to be more intense in nature. So, what I mean, I mentioned the girl in my clinic that I saw. She was 8 or 9, I can't remember, super interested in Spice Girls, like loved Spice Girls. She had a like I said, she had certain days where she listened to certain songs, and her parents reported she would listen to like those same songs like 50 times in one day. So when I mean that, like they're restricted, the repetitive behaviors, how many of you have girls who listen to songs like 50 times in one day and do that week after week after week if they're not somewhere on the spectrum? That to me was like a pretty big red flag of like, ooh, she's got some restrictive behaviors, some restricted interests going on here. Um, they reported that she had been doing that for about 12 or 13 weeks. Um, every Tuesday, she'd listen to the same song like 30 to 50 times over and over and over after school. And they just were so sick of these songs. Um, then for boys, you might see kind of like a little bit more odd ones. Um, where they are super interested in something like rocks or super interested in something. I'm trying to think, I don't see as many boys, but I see a lot of times that like it's something about sciency or something that's really specific, math problems. I had a guy who came in a couple months ago and he was talking about how when he was little, he really, really liked to like deconstruct computers, take them apart, and then put them back together. Like that was his thing. And for a 5 year old, that was not socially appropriate. You will see, Tiki is saying things like dinosaurs. You will see things like dinosaurs. You will see shows, cars, airplanes. And so those are some of the more socially appropriate ones for boys, but again, they can be to the extreme. So for girls, another thing I see is like princesses, unicorns. And so they might look kind of socially appropriate. When you dig in, they are way too intense. The Spice Girls child that I'm talking about, she also had certain outfits that she wore on certain days to correspond with her songs. She had certain dances that she did. It was just way, way intense. Um, and so this was to me like, okay, this girl is really on to the Spice Girls. And you'll see these interests ebb and flow. They won't stick on them forever, but there's a very similar pattern of they love them and they're on them. Um, Sensory interests in activities. So ask questions about smells. Ask questions about the foods they eat, about the clothes they wear. A lot of times you'll see stuff come up with hygiene with girls. Like they might not like to wear makeup. They might not like to fix their hair or have their hair combed. Showering may be a huge issue for them because of the way the water feels, the sense of soaps, the way the soap feels. These are really big questions that you want to ask because that's sometimes how sensory interests can come up. So I really kind of want to ask if there's any questions about these criteria before I kind of move on to how ADHD presents in women and girls. And I think I mentioned sometimes that there's some other stuff that will come up diagnostic wise for women. So you might see them present with like chronic anxiety and mood disorders. And even though they've been treated for this, they might have been treated multiple times, tried multiple different medications, um, and they're not making progress. So that might be a red flag of like, hey, maybe something else is going on here. Um, Borderline personality disorder is one that I see. Um, Trauma is one that I see. And this is really tricky. A lot of times, severe chronic PTSD can present as um, autistic traits. And so that's something to really kind of think about and dig in with and get some more specific information. A lot of times they might have been diagnosed with like ADHD and anxiety, but there's more going on. So that's something to also consider. Um, and if these symptoms that they have are attributed to other disorders, it can delay diagnosis and really make it difficult for them to get some of the services or the treatments that they need. All right. So ADHD in women. Um, this is something that I like could geek out about for hours, guys. So if I get kind of lost here, I will try and stay on topic. Um, this one is a little bit more straightforward. You have your inattentive side symptoms and your hyperactivity symptoms in women. Um, but we also know ADHD does not just come with inattentive symptoms and hyperactivity symptoms. And so you also have some other stuff that's not strictly in the diagnostic criteria, but are common presentations and common things that come up in women. And so I will talk a lot about those as we kind of get through this here. Um, I'm curious, when you guys think about ADHD in women, what are some of the common challenges that you think about that they present with? And maybe think about like boys with ADHD. What are some of the differences that you see with women compared to males, if this is something that you see in your practice or your clinic? Difficulty maintaining friendships, relationships. Um, Yeah, struggling to complete tasks is a big one. Takes them a long time to finish things, or maybe they have a lot of unfinished projects. Great, guys. What are some other things that you guys see with ADHD in women? Um, Too many tabs open in the brain, causing it hard to focus on one thing. Yeah, so just like all these things going on in their mind. I have a lot of thoughts about why that is for women. Um, but yeah, I think the difficulty maintaining relationships and friendships thing is really interesting to think about. It's not directly in our DSM criteria, but if we look at the presentation of like inattentive symptoms and hyperactivity, it can kind of explain a lot of why that's um, difficult. Is hypersexuality a symptom of women? Absolutely. Absolutely. I will definitely talk about how hyperactivity symptoms present differently in women and how you can kind of think about how that might look for women compared to men with hyperactivity, because sometimes they present very, very differently. Okay. So, um, thanks for that, guys. I really appreciate that. It makes it so much more fun for me. Um, so, like I said, there are some things barriers to advancing professionally due to symptom interference for sure, guys. So sometimes you have women who hit this ceiling in their professional careers because they're of their executive functioning impairments or sometimes even social challenges where they have a hard time advancing professionally. Um, so there's also a lot of comorbid mental health problems that come up with women. Oh, I got ahead of myself. Let me go back here, guys. I'm so sorry. Um, Okay, so the inattentive type symptoms in women, this is way more of the predominant symptom in women. They will present with way more inattentive symptoms compared to men. Um, so what you guys kind of mentioned about difficulty finishing tasks, um, taking longer to finish things, having too many tabs open in their mind, lots going on in their head, and just bouncing from one thing to another. That is definitely something that comes up in women. Um, they might have some masking or like compensatory behaviors, camouflaging things that they do. Um, Another thing you'll kind of see in women is that they are very disorganized, have a really hard time managing their time. They procrastinate a lot. And then there's some anxiety that comes with the procrastination, like when they hit a deadline. You might see women who seem organized in one area of their life, um, but then there's like they can hold it together in one area. But if you look at other areas of their life, it's like chaos. Um, so they're constantly like having to go back in the house to get stuff. They're constantly having to run home because they forgot something. Um, can't find their keys, can't find their wallet, can't find whatever. I struggle with ADHD myself, guys. I can't tell you the number of sunglasses that I have lost. I cannot buy expensive sunglasses because I probably go through like 10 to 12 pairs of sunglasses a year. I constantly leave them laying around and lose them. So those are some things that you see. Like they're doing something and they're looking for what they just had 2 minutes ago. Like it's a problem. Um, and so their impairments in their functioning, in their work, their home life, their relationships can really come to because a lot of this disorganization, this problems paying attention, people might get frustrated with them because they're like, I told you that. But they really don't recall or remember these things happening or people saying these things to them. So when you think about women who have a hard time advancing in their careers, it might be because they're forgetting or they're not getting things done in a timely manner. They might be taking a lot longer than some of their peers who aren't neurodivergent to get things done. And so their bosses kind of pass them up for those promotions. Um, in relationships, so some of the challenges come with like problems with attention. They don't pick up on some of the more subtle nonverbal cues. Um, they might be forgetting things that people say in conversations or drifting off during conversations and thinking about their own, thoughts and then interrupting or having trouble filtering things that come to mind. And people can find that really off putting or kind of rude at times. So, those are some of the things that can kind of come up with inattention type symptoms. Um, Women tend to have more like subclinical type symptoms in childhood. And so, one thing to think about is are there times in their life where it's a transition period? So, I'm going to tell you some common things that I see. They are able to like compensate, and especially intelligent women, they can compensate, they can get through. until a point where like the demands outweigh their ability to their skills and their ability to compensate. So some common times that I see this are middle school, high school, college, first job, motherhood. These are some 5 common transition periods where girls and women will have been doing okay. They're kind of like that like subclinical threshold, but the demands will increase and their ability to manage will decrease. And then the symptoms become way more pronounced. It's not that they weren't there before, they were. They were just able to manage the demands a little bit better and kind of work through them. But something changed in their life and it kind of put them over the edge. So that's something really to be aware of. Their impairments in executive functioning persist throughout their lives. Um, it's not like they're going to go away. You see these, like when I ask about history with women, they'll talk about how they struggled with this, and it's just kind of become it's persistent and it's causing more problems over time for them. So that's something to also be aware of. Um, Hyperactivity symptoms. These are not as severe in women as we often see them in males. They're less severe, but they also present differently. So somebody asked about like hypersexuality. Um, when we look back at those studies that I talked about at the very beginning, um, some of the long-term outcomes that caused some problems for women were promiscuity, excessive drinking or drug use. Another way that you can see hyperactivity or kind of like impulsivity presenting in women is self-injurious behaviors. They get really dysregulated and they impulsively cut, burn, hurt themselves in another way. So that's really something to be aware of, guys. Asking about cutting, burning, because it's really like this impulsive behavior to want to get some relief. And that's way more common in women with ADHD than in males. And also, when you think about women with other mental health disorders, self injurious behaviors are also way more common in women with ADHD. And they also have like high risk hobbies. These women might really be into, I don't want to say they're high risk, but some of them are high risk, some of them are just very active. They might be into really sporty things, CrossFit, weightlifting, running. They might like doing things, um, skydiving. They might like doing um, stuff that really just keeps them active, motorsport, skateboarding, things like that, that maybe you don't always see in women who aren't neurodivergent. So those are some ways that you might see hyperactivity present in women. Another way that you see it present is verbal hyperactivity. So what I mean by that is they talk a lot. They talk a lot. They talk quickly. They interrupt. They speak loudly. That is one of the ways that can present for hyperactivity. Um, and this can cause a lot of problems in relationships. They feel like they dominate the conversations. They feel bad for interrupting others. People tell them they're too much. Um, and so that's something that can cause them to feel guilty or feel like um, they're they don't deserve to be in relationships. Um, so that's something to kind of be aware of. Um, and one other way that it can present as women is this like internal restlessness. So they feel like they can never relax, that they constantly have to be doing something. They have a hard time like sitting still or just feeling like they constantly need to be busy. And so this can be really great. I've seen this especially for some of my higher functioning women where they're really good at what they do. They are constantly busy, they are constantly working. They've kind of made good careers for themselves because they need to be busy. They're high achieving, but it also causes a lot of problems with burnout because even when they want to stop, they do not physically, like their bodies, they feel like their bodies physically and mentally will not stop. Um, so this can be a really big challenge for women, um, and something to kind of be aware of. Sometimes I think that can be misinterpreted as anxiety. Um, and it's not that it can't be anxiety. A lot of times they go together. The rates of co-occurring anxiety and ADHD in women are like almost 50%. So it's something just to kind of think about. But I hear this from women a lot. So, any questions about hyperactivity symptoms before I kind of go into some of the other ways that ADHD can present, that aren't covered by the DSM, or inattentive symptoms? I know I covered that too. But you guys asked some really great questions about, um, or had some really great thoughts about how ADHD can present in women. So, I want to make sure if there's anything else before I kind of move on. Okay. Well, I'll go ahead and kind of keep going here. Um, Some of the other challenges that you might see in women with ADHD, we talked about one of them already, is like the problems with relationships. Emotion regulation is another really big issue. Women with ADHD tend to have really big, intense emotional reactions, to situations that might not be, that the reaction might not be warranted. Um, so I think that's sometimes where the cutting can come in. They have these emotions and they need to manage them. So they have this intense kind of impulsive reaction in cutting. You might also see, because they have trouble kind of monitoring their own emotions, they might not be the greatest at kind of noticing as things are building. So when we talk about awareness of emotions, they might have a harder time paying attention to those subtle cues and being aware of those things, but then have this like big blow up or big intense reaction to emotions. Sensory sensitivities is another common presentation of ADHD in women. So they will see some of the, like, they might be easily overwhelmed by noises or get overstimulated in social situations, might have some weird, quirky food things or things about clothes. So just kind of be aware of them. They are not usually to the extent that you see in women with autism spectrum disorders. Um, Again, lots of high comorbidity with other mental health conditions, overcompensation and camouflaging. So that's common across both disorders. How many of you have heard of imposter syndrome when it comes to ADHD in women? Because this is a really common phenomenon of that we see a lot, not only in women, but kind of just ADHD and the neurodivergent community in general. Um, what this is feeling like this feeling of not good enough, or that people are going to find out that they aren't able to do things to a certain level. So this is something that I hear a lot of women talk about, especially like when you talk about their careers or motherhood, relationships. People are going to find out that they're camouflaging. People are going to find out that they can't keep up at this level, or it takes them way more effort to do things. And they're very afraid of that, very fearful and anxious that somebody is going to kind of like find them out. Um, Sometimes they will attribute their success to external factors. And that's part of imposter syndrome. So they'll be like, I just got this job by luck. I have no idea how I fell into this job. They don't really give themselves credit for doing well. And part of the reason for this is because people who have ADHD tend to get more criticism, and negative feedback because of some of their challenges and have a hard time kind of attributing their success to some of the things they do well. So let's talk a little bit about hormonal changes because somebody asked about this. And I think it's really important to consider with women. And there's not much research out there about this, guys. It's really hard to track because this is so individualized and so specific to the individual, but there are some like broader patterns that we know. Estrogen in women decreases the impact of ADHD symptoms. So, when estrogen is high in women, so during our menstrual cycle, during pregnancy, that kind of stuff, we tend to have less severe symptoms. It's kind of a great thing. So you might see women who have ebbs and flows in their symptoms based on their menstrual cycle, based on where they are in menopause, perimenopause, things like that. Um, so know that kind of these symptoms can ebb and flow. There was a question about medication as well. There's some kind of, I don't want to say research, but some like anecdotal information coming from like questionnaires from women and just asking women about this, that when they're taking medication, the medication, and I don't think it's that the medication is more effective, but that we see less severe symptoms during in the time leading up to their menstrual cycle and the first half of their menstrual cycle. Women also report less severe symptoms during pregnancy when their estrogen levels are high. Women report more severe symptoms during perimenopause and menopause as their estrogen levels are dropping. So this might be something to be aware of. Post-gynecological surgery. So, like if somebody has a hysterectomy, I'm not an expert in this, but I would guess um, if their estrogen levels are dropping, they're going to have more severe symptoms. We don't exactly know how, I'm not exactly sure the appropriate term for this, but if you're given hormonal therapy or kind of like artificial estrogen, how that really impacts ADHD symptoms. So, my clinical suggestion here, be in like do some research, guys, talk with gynecologists in your area. They also don't know a lot either, and so sometimes it's like a process of educating each other. Ask women about their experiences. Don't be afraid to like ask, have conversations. I've talked with some psychiatrists about like, do we use birth control to kind of manage some of these symptoms? Does it make sense to increase doses of medication during certain times of their cycle if they're consistent and track them, to decrease the impact of their symptoms when they're worse and take a lower dose when they're in their menstrual cycle? These are all things to kind of think about when you are considering treating ADHD in women or working with another clinician who's treating the ADHD in women, because that their hormones are definitely going to affect it. So when I talked about transition periods for women too, um, sometimes you'll see girls in puberty where things start to get kind of wonky because their hormones are all over the place. Um, women who after pregnancy, when their hormones are kind of the estrogen levels are dropping, you'll see that like they have a really, really hard time with their ADHD symptoms. And part of that is like the demands of motherhood increasing, but also part of it is their estrogen levels dropping and that their symptoms are getting worse. So those are things to consider. Um, are there any other known relationships Are there any other relationships between other hormones and ADHD symptoms and with women such as testosterone? Sorry, guys. Um, I don't know the answer to that. I can look into that and get more information. I'm not 100% sure, so I don't want to give an answer that is incorrect. Like I said, this is definitely an emerging field and something we're learning more about. So I'm happy, Kristen, to kind of look and give you some more information and kind of pass that on if I can find that. Sorry, I don't know a direct answer to that. Um, okay, so I'm going to skip through some slides I have here because we've kind of talked about some of these things, and I want to give you guys some practical tools to kind of work through here. So, if you work in a clinic where you're looking at kind of using some type of tool to screen for ADHD or autism in women, I want to make sure that you have some tools that are available to you. So I've used this in my other trainings. If you've ever been in one of them, I am going to put this out there. Screening, some of the screening measures I'm going to share with you should never be used alone. They need to be used in conjunction with interviews, behavioral observation, historical data, other mental health screening tools. And when you are assessing for autism spectrum disorder or ADHD in women, you need to look at other stuff. You need to look at anxiety. You need to look at trauma. You need to look at depression because these things co-occur at such high rates. If you're not screening for them, my guess is you're missing something. Um, so I'm going to go through some of these screening tools for ADHD, and I'll talk about which ones and kind of what they do, so that you guys have some information and can use them. So the Conners ADHD rating scale, the CARS, the ASRS, and the Copeland and the Brown. These are basic rating scales for symptoms that are presenting now in adulthood. The ASRS and the Copeland are free. So if you're looking for a measure that you can use in your clinic without costing you anything, those would be my go-to. The CARS and the Brown are measures that you have to pay for. So that's just something to be aware of. Those you can use in conjunction with one another. Sometimes I'll suggest using both just to get like see if people are consistent across the board. So you can use these to just kind of get an idea of how severe their symptoms are compared to other people their age. Because sometimes people might report these symptoms and they might be like just minor symptoms that come with anxiety, come with depression, but aren't to the severity that we would see in ADHD. And so these kind of give you an idea of if these rise to the level of ADHD concerns or not. The Winder Utah rating scale is a great scale that looks at like historical information. What were their symptoms like in childhood, middle school, high school? And not just like those inattentive symptoms, but some of like relationship challenges and difficulties. So I really love using this scale to kind of look back at time and see if some of those symptoms were present before adulthood. Um, the DIVA is a diagnostic interview for ADHD in adults. So that's a great one to combine with some of those other rating scales to look at from both like an interview perspective and then an objective perspective. It's a structured tool and definitely something that can be useful as part of your like interview or intake battery as well. This measure I just actually became aware of, the adult ADHD masking measure. So it is in, this is like a brand new thing, guys. It's still in validation. It's not been fully validated and published out there yet, but I will tell you, I'm using it as kind of a measure to see how much my adults are masking. How much are they trying to compensate for these behaviors? And the way that I find this helpful is like if other people in their lives are saying, like, hey, they're not super impaired, I don't see any challenges. But if they're really masking, this is a super useful tool to be able to say, well, you might not see that because they are masking. And it might not come across as something that other people see as much. And so I really, really appreciate having a tool like that for both ADHD and autism when I'm doing assessments for my clients. Any questions about these rating or screening tools for ADHD, guys? before I move on to the autism specific rating scales. Um, None of these scales are specific to women. All of them can be used for males, females, but these are all specific to adults. These are not scales that you would want to use when assessing children. If you are in need of some scales for assessing children, drop that in the chat, and I'm happy to kind of give you guys some other scales that you can use for assessing children as well. The Connors has a couple of different scales than you that you can use. I can send you that information. I always send Choya the scales. I have them pulled up already, and I'm happy to send you guys these PowerPoints so that you can have these scales. I will not be able to send you the paid versions of these scales, but I am happy to send you these um, scales so that you have them in your toolkit. Because, like I said, I want people to be able to walk away with some practical things they can add to their practice right away. That's something I think is really important in training. So I'm happy to send them to Choya as soon as I finish up with my section of the presentation so he can pass them on to you. Um, Another child one is the Vanderbilt assessment scale. That's widely free, can be used. The one thing I don't like about the Vanderbilt is it doesn't have norms to compare against other children. It's basically just like a symptom checklist. This is something that pediatricians commonly give when you go there for like concerns about ADHD. So that's my caveat with the Vanderbilt. All right, tools for screening for autism. So most of these are widely available. So the autism quotient, the RADS-R, the camouflaging autistic traits questionnaire, the modified girls questionnaire for autism, and the adult repetitive behaviors questionnaire are all widely available and free to use for screening for autism. The social responsiveness scale is a paid measure. And so these ones you can find pretty freely on the internet if that's something that you're looking at. The modified girls questionnaire for autism is one that like it is pretty specific to females. Um, Autism quotient can be used for people ages 16 and up. I think the rest of these are 18 and up. But the social responsiveness scale actually goes down. I'm trying to remember if there's a preschool version, but it goes down to ages 5. So if you're using this with kids, that can be something that can be used with children as well. I often use some of these in conjunction. I really like using the camouflaging autistic traits questionnaire, just kind of like I mentioned as well, for the ADHD measure to kind of get a sense of like, are other people seeing this? And if not, why? When I'm doing a comprehensive assessment, I also give rating scales to go to teachers, to parents, to partners, or another close family member to help kind of get an idea of what other people are seeing as well. But these measures are all specific for the person who is experiencing those symptoms. Okay. So the last one thing I want to talk about is like, when do you refer for like a comprehensive diagnostic assessment with a neuropsychologist, with a psychiatrist who can really do a little bit more in depth and kind of teasing apart some of these things? So there's a couple of reasons. If you're wanting to tease apart what diagnoses is this person, what makes sense for them. So sometimes we have somebody who has anxiety, depression, some OCD or trauma, in addition to concerns about neurodivergence. That is really helpful to kind of sit down and tease apart, guys. I see people who have been treated for ADHD and anxiety for depression and anxiety for a long time. And then there's some underlying condition that kind of stalls their treatment that they're not getting diagnosed with. So that can be really helpful because you can really get some specific treatment recommendations once you have some clarification on diagnosis that you can kind of help to move forward with treatment. I really recommend that you don't send them to like a general, if you can help it, just somebody who does generalized assessment. Try and find somebody who specializes in this in your area, especially for adults, or at least kind of understands ADHD and autism in adults. I've had so many people come to me and say, like, I had awful experiences with certain clinics or certain clinicians in the area who didn't really understand it. And they come to me for second opinions, and their experience, whether or not I diagnose them with this or not, is very different. Just because they have someone who's kind of coming to them from a place of understanding neurodivergence and approaching them a little bit differently. Again, if people are having difficulty making progress in therapy, this might be an area where like let's get somebody else to look at this and see kind of what's going on. If they're in a time of transition and you see more severe functioning in their impairment, you might say, hey, we need to have someone check this out, see what's going on. A common reason that people come to me is they need accommodation for work or for services. That is something that sometimes you need a neuropsych evaluation for. ACT, job accommodations, getting a diagnosis for certain services can require more of a specialized assessment. Other times people come for an assessment just because they want to better understand themselves and get validation of their diagnosis, which is a completely valid reason to come in and get an assessment as well. They maybe have self-diagnosed themselves or starting to look at some of the stuff out there and are considering it, but they want to know for themselves rather than kind of guessing. So these are some reasons why you might refer for an assessment or kind of think about doing that. So that is all I have for you guys today. Um, are there any questions that you guys have for me, whether it's about stuff that we've covered, about neurodivergence in general? I have a few more minutes, so I'm happy to kind of take questions. If it's easier to, if you can unmute yourselves, feel free to unmute yourselves and ask directly. If not, you can raise your hand and I can see if I can unmute you. I'm really happy to kind of do what works for people. I hope you guys found this to like give you some better information about just neurodivergence in women and what it looks like. Because I know this is something that we're learning more and more about. And my hope is that uh, you guys can take this back to your practice and be a little bit more informed as women come in and might have some of these challenges and need some additional support, that you can be a little bit more neurodivergent affirming and help them get the support and resources that they need. Any questions before I turn it back over to Choya and let him do the next presentation, guys? I want to thank you for your time. Thank you for your interaction. I love presenting on this topic. And I really hope you found it helpful. And I will definitely email Choya the PowerPoint and some of those measures that I mentioned to you so that you can have them available to you and use them in your practice.
Jennifer, let me just see if I can hold you on just a couple more minutes because we're gonna have some dead time, um, and maybe we could get a couple more questions in while we're
Sure.
trying to get the next person set up and Dr. Lewis to join us, um, uh, you know, shortly. It's crazy because I just did I did an EMDR training not too long ago, and there was you know, it's interesting. until you start bringing attention to what neurodivergence is, sometimes you miss so much. And I didn't realize that for some individuals, because I don't like to generalize that suffer or not suffer that experience, we have to watch our terminology, that
Yep.
experience neurodivergence, particularly from the standpoint of autism. I ran into two individuals at the training, and they were experiencing that, and they were sharing their experience. But I didn't understand um, how they viewed themselves so much differently than everyone else. Uh, Even had references to people, what they called individuals who were not neurodivergent, what they call, I can't remember the term, normies or something like that. It just
Yeah, you have different language that people use, like neurospicy. You'll have people use a lot of different language that comes through in the neurodivergent community, which is so interesting.
Yeah. And can you give some perspective on someone who is experiencing let's just say a female that's experiencing autism. Can you share with us some perspective? Because I didn't realize some of the statistics, and you could just share as much you know. I know I'm coming out kind of random, but
Yeah,
I don't
sure.
know how many of you all are aware of for again the focus is women, the numbers of women who have been sexual women and girls who have experienced sexual abuse, who have diagnosis of autism. Can you shed some light on that and why that occurs, and that it's I mean, the way that in the woman that I was talking to, I wouldn't even be able to know that she had, autism, because she's functional, high functioning, things like that. But then also, I've studied and read about how the higher functioning individuals sometimes are the ones that have more of the the aggressive suicidal ideations and things like that. Can you share some of that information with?
Yeah, I love that you bring this point up because um, I didn't know this when I really kind of started digging into this and learning more about it, and it's been very eye-opening for me. And so I see this not only in autistic women, but I see this in women with ADHD too. And I think there's a couple reasons why they're at higher risk for experiencing trauma. And so I'm going to start with autistic women, and we'll kind of go from there. So, when we think about understanding social norms, interpreting social cues, things like that, women who are autistic might misinterpret things. Might if they're in like in a setting one on one with another person, whether it's male, female, whatever, um, in a club where people are dancing and doing things, they might have a hard time picking up on some of those like social expectations, norms. Um, if somebody is touching you in a sensual way, they might not pick up that or kind of understand that that is meant to be romantic. And so things might kind of start to progress and they're just not picking up on that.
Not picking it up.
um they're not picking up on that, and so it can be something where they are in a situation that they didn't expect and things go from one way to another, and they might have a hard time articulating or saying no. They
Mm.
might really struggle, and this has been kind of my experience, to say like I don't want this. They
And
might be
that's what I heard
afraid.
is a big factor too.
Mm-hmm.
For a
they
number, what's some of the reasons why?
women women who are autistic have already had so much rejection. They've already experienced so many social challenges. And so I think there's, and I think that comes for women in general. I think it's just so much more amplified for women who are autistic that a lot of anxiety, they kind of have this freeze reaction and they just aren't able to say that. And so the person who they identify as sexually assaulting them. This is kind of, this becomes a very tricky topic. That person might not even realize that the autistic woman feels that way. Um, it can get very, very tricky because they might not have understood that this, or the woman might not have articulated this, but that woman might feel very violated and that she was taken advantage of. And so it's so tricky, so difficult to kind of help um, piece through uh, for women or people who identify as women in those situations. So I think it's something just to kind of be aware of. I don't know that I have a good answer to that other than helping these women to be able to work on assertiveness skills, learning a little bit more about intimacy and relationships if you're treating this. For women who have ADHD, we talked a lot about like impulsivity and how sometimes their hyperactivity and impulsivity can present as promiscuity. It can present as excessive drinking and drug use. Um, so they might put themselves in higher risk situations.
Mm,
And I do not want to place any blame here because I don't think it is okay for anyone to take advantage of anyone. But when you put yourself in a higher risk situation, I think that there is just a higher risk of experiencing trauma,
yeah.
whether that's sexual trauma, whether that is somebody physically assaulting you, you are just in a higher risk situation.
Yeah.
And so I've seen that happen time and time again, where they do have ADHD or they do have autism and they've also experienced trauma. And so it's really, really important to kind of tease out, when did these symptoms start presenting? When did the trauma happen?
Yeah.
Um, when and kind of what's the timeline of things? And so if you think about like a comprehensive assessment, that's a great reason to come in because if they've had childhood trauma, that might be one thing you're kind of thinking about. Is this more of a childhood response, a traumatic response? But if they've experienced a lot of trauma as an adult or like even as a teenager, that's a whole nother thing we have to kind of like start timeline to think about. Um, because there's a lot of research that says these women are just at such higher risk for traumatic experiences, for women having unplanned pregnancies, um, higher rates of STDs. Like there's just so much research out there. And I think that's one of the things those studies that I mentioned at the beginning, kind of as they followed the women, they saw these differences over time. And we didn't realize when we first started kind of looking at ADHD and autism in women, how it impacted their long term, like life, quality of life, functioning, things like that. And because of some of the, I think, higher risk of pregnancies, not completing education, you also have women who are not making as much as other women who aren't neurodivergent or
Mm,
having these conditions because they're not able to get um, college degrees, get some of these higher level jobs. And so you have a lot of poverty and things like that that come into.
wow. Yeah, it's a lot that you learn as you get deeper exposure to the various uh, diagnosis and conditions that many of us experience. And so this added perspective, the tools, and it's just been super helpful, Dr. Ritchie, and we certainly appreciate you coming again, once again, and presenting for us. And I know that everyone enjoyed. Thank you so much. And we'll be talking
Yes.
to you soon, Dr. Ritchie.
Thanks,
Thank you
guys.
so
Enjoy
much.
the rest of the presentation.
Awesome. Awesome. Thank you. All right. So as we transition to get our next speaker set up, we're going to allow for you all to take a 5 minute break. And I think we should have everything squared away by then. So we will try to check back at 10:35, and God willing, we'll have everything set up and ready to go. Thank you all. Okay, okay. We are back and ready to start the second phase of this DSM training. I hope you all have been enjoying it so far. Um, we are just so pleased to have our next presenter. She's got some great things to share with us today. And so we have none other than Dr. Jalen Likely. who was already on, by the way. I'm just over here freaking out, not knowing what I'm doing. I can't multitask. But she was already on. So we're gonna read the bio and turn the mic, turn everything over to her. But let's read this bio. Dr. Jalen Likely is originally from Memphis, Texas. I mean Memphis, Tennessee. All right. And she is a proud Afro-Caribbean with origins from the Dominican Republic and Haiti. As a first generational graduate, Dr. Likely has embraced every opportunity to forge a path of academic and personal achievement. Dr. Likely began her scholarship or her scholastic journey at the illustrious historical black college, Miles College, located in Birmingham, Alabama. After graduating with a bachelor's of social work degree from Miles College, Dr. Likely became a recipient of the prestigious early offer Inclusive Excellence Fellowship at The Ohio State University. You know, we got to talk. That's my alma mater. Hello. And we're going to the championship. We shouldn't date this. All right. Uh, but after graduating, let's see, during her matriculation at the Ohio State University, Dr. Likely completed her field practicum at the Department of Veterans Affairs Hospital in Dayton, Ohio, where I was born, where she received a stipend to support her professional goals. Dr. Likely is a proud graduate from the doctoral in social work program at Capella University. Dr. Likely completed a qualitative study using generic qualitative inquiry and an action research methodology. She collected data on how African American social work clinicians experience, identified, and address microaggressions in their professional setting. Presently, Dr. Likely is breaking barriers as the youngest social work supervisor in the nation's largest healthcare facility for veterans. And without further ado, we are so pleased to have Dr. Likely to present today. Thank you for being here.
Thank you. Thank you for that amazing introduction. I am just so overjoyed to be here and have a conversation, right? I want to look at this as more of a conversation rather than a lecture or educational lecture on understanding schizophrenia spectrum. So, again, I am Dr. Likely, and I am very excited to get this presentation started. So, one thing that I really like to do whenever I do any sort of a presentation, whenever I'm speaking or hosting a meeting, I really like to check in with the audience. So, I really love engagement. So, I want to hear about y'all's current feelings, your emotions, because when you share that with me, it helps me to understand how can I better connect with the audience and how can I make sure that I am addressing any needs that are being presented, and also, just by sharing your emotions and your feelings of how you are presently, it creates that open dialogue that's going to make this presentation meaningful. And that's needed when you are in a learning or an engagement environment. So, if you don't mind coming off mute or just posting your favorite emoji or your GIF in the chat box, just so I can do a nice temperature check on how everyone is feeling on this great Tuesday morning. I love it, Haley. Haley is all smiles. She is eager to learn. Penny's terrific. Christy is feeling loved. I love it. Oh, yes. Oh, we got some shocked emotions like, all right, what is today going to entail? It's going to be a good time. I promise you all that. Definitely going to make this an enjoyable experience. Absolutely. Oh, Courtney, we're going to change that squiggly face to something that's smiling, right? We don't want any hesitations. Yes, yes, yes. Absolutely love it. We got smiles, we're high energy. This is good. All right. So thank y'all for participating in that nice check-in. So for today, I am going to talk about the schizophrenia spectrum. So, schizophrenia is a complex mental health condition that is characterized by key features. These features can include hallucinations, delusions, disorganized thinking, negative symptoms like the lack of motivation or that emotional expression. As well as this, so these symptoms can significantly impact a person's ability to function in their daily life skills, right? So the development of schizophrenia is actually influenced by a combination of biological and environmental factors. So, biologically, when we think about schizophrenia, we know that there is an imbalance in the brain, right? We have these chemical imbalances like dopamine, we have this genetic predisposition in our instructional brain abnormalities. So, this plays a vital role in diagnosing schizophrenia. Now, when we look at the environmental factors, we can consider those factors such as early trauma, chronic stress, prenatal complications can also increase the risk of having that diagnosis of schizophrenia. So, my goal for today is to ensure that you all have a sound understanding of the schizophrenia spectrum and understand how these influences. We can approach this in a more holistic way where we can have that combination of medication therapy, look at our support systems, and then look at how can we improve these outcomes for these individuals that are diagnosed in any level of that schizophrenia spectrum. All right. So, what I am going to introduce to you all, it will be brief psychotic disorder, schizophreniform, schizophrenia, schizoid personality, and schizotypal. I'm sure you're looking at this list like, oh my goodness, we only have an hour and a half. How are we going to get through all of these diagnoses, right? So, how I plan on doing this is giving you the information that's going to be needed so you can quickly differentiate this is not going to be this diagnosis, right? I want to make sure that you are all have that understanding of this is the duration, this is the frequency, these are the symptoms that's being presented. And if I know these three things, I have that foundational knowledge to where I can differentiate and I can make that diagnosis that's going to be educationally based. So on this next slide, definitely want you all's participation. I am going to read this verbatim, but then I'm also going to come back into this scenario and I want to hear from you all because I want to know what sticks out to you when we read this scenario. And as we read it, I want you to be picking up on some of those key factors that's going to help you diagnose or pick a diagnosis, right? So really focus in if I mention anything on duration, anything on those symptoms, anything on the frequency. I'm going to sound like a recorder. So I'm going to say that so often, but it's so important that we have that. So we have a 27-year-old woman presents to the emergency department after her family became concerned about her sudden bizarre behavior. 2 days ago, she began speaking incoherently, claiming that she could hear voices of angels warning her about an impending disaster. Now, she also exhibited disorganized behavior, such as rearranging furniture frantically because she needed to protect the house. So her symptoms began shortly after her fiance unexpectedly ended their engagement. She has had no prior psychiatric history, no history of substance use, and her medical workup, including that toxicology screening, is unremarkable. Now, within 2 weeks of receiving supportive therapy and antipsychotic treatment for her symptoms, they fully resolved. and she's returned back to her baseline functioning. So now that we've kind of read through this scenario, I'm going to ask you all, as we go through this, what are those key things that's really sticking out to you that's like, oh, that's something important. I need to know that. Maybe that can help me diagnose. So so we know we have a 27-year-old. Where's this 27-year-old presenting? And definitely feel free to come off mute, or if you want to just throw it in the chat, that's perfectly fine as well. Absolutely. So we have this 27-year-old. She's presenting to the emergency department. But why is she at the emergency department? What's going on with her behavior? Yeah, auditory hallucination. Absolutely. So sudden onset of disorganized behavior. Absolutely. Now, what's disorganized though? Like, what is she doing? Why are we going to say she has bizarre behavior? Because we could say, oh, it says it right there in the rationale, but what what is she actually doing to display bizarre behaviors? Paranoia, absolutely. Hearing voices, yes, 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 yes. She believes that angels are warning her about an impending disaster, right? She's rearranging furniture. She's like, all right, I need to move this chair over here by the front door. I need to make sure that it's blocked because I need to protect my house, right? So we see that paranoia. We absolutely see that bizarre behavior. Excellent job. Now, I'm going to ask y'all something this. When did these symptoms begin? Oh, absolutely. Triggered by that traumatic life event. Yes. After the breakup. Isn't that something? Like, wow. After this fiance just unexpectedly ended their engagement, we see that this 27-year-old has this bizarre behavior to where she is frantically moving furniture. She's hearing voices of the angels saying, hey, you need to prepare because there's going to be a disaster. This happened after a traumatic life event. Now, something that's also super important that we want to mention whenever we're doing a diagnosis, we want to make sure that there is no reference of we want to rule out medical, right? Rule out medical. We want to make sure that there is no interference of a substance use. And then we also just really want to pay attention to her history. So all of this is going on after the breakup with the fiance. It's unexpected. She's hearing voices. She's frantically moving furniture. But after 2 weeks with just supportive therapy and antipsychotic treatment, her symptoms fully resolved. It's gone, right? So this was not a long period of time, right? After 2 weeks, these symptoms resolved. If you were looking at this, what diagnosis would you anticipate that this 27-year-old has? And if you're not sure, just be like, I don't know. Right? Psychotic break. Yeah, absolutely, Pam. Absolutely. Any more guesses here? Bipolar disorder, schizophrenia, brief. All right. Hey, brief psychotic. Yes, yes, yes. Awesome. Haley, Miss Land, absolutely. Brief psychotic disorder. That is exactly what's going on in this scenario. Uh-oh. There we go. For some reason, my picture did not pull up there. However, so the rationale is definitely going to diagnose as brief psychotic disorder. So when we have this diagnosis, this is a thought disorder, and it presents as like an abrupt abnormality. And it's like those abnormal appearances of psychosis. So, brief psychotic disorder is literally a break from reality, right? It's that break of reality, but we want to make sure that there's no influence of physical health. There's no influence of substance use. And we know that back in this scenario because it lets us know because of her medical workup, including that toxicology screening, there's nothing. It's unremarkable, no history of substance use. So that is super important when it comes to the diagnostic factors. Now, I'll tell you this when it comes to brief psychotic disorder, individuals, they can have more than one brief psychotic experience. However, their symptoms cannot last longer than 1 month, okay? And it has to be unrelated to other diagnoses. Absolutely, Haley. That timeline gave it away, right? Brief, something short, does not exceed that 30 days, that 1 month. So, literally, from when we look back at our DSM 5 TR, because we have that text revision now, by definition, a diagnosis of brief psychotic disorder requires a full remission of all symptoms and eventually a full return to their pre-morbid level of functioning within that 1 month of that onset disturbance. So we need to see that they are going back to their original presentation. They're going back to those daily skills. They're able to function in life without any disturbances or any triggers, right? Now, how does this come about? Like, why do we even think about brief psychotic disorder? How is this triggered, right? So, brief psychotic disorder, it can be triggered by extreme stress, just like the one that we saw in the scenario where it was that unexpected breakup with the fiance. So, extreme stress, traumatic accidents, maybe the loss of a loved one. These are things that can possibly trigger a brief psychotic disorder. And individuals that are displaying these symptoms, displaying these behaviors, they may not even notice that, hey, my behavior is strange. They may not notice that. So, although brief psychotic disorder, by definition, reaches a full remission within 1 month, more than 50% of individuals experience a relapse. Isn't that something? So, despite the possibility of a relapse, for most individuals, the outcome is going to be favorable in terms of returning back to that social functioning. Now, as mental health professionals, as a social worker like myself, typically when we are going to diagnose brief psychotic disorder, we're going to make sure that we are completing a thorough assessment. We're going to make sure that we are assessing their full medical history. We're going to consider that physical exam and we're going to complete that psychosocial assessment because we need to have a solid and sound understanding of what actually is being presented because we don't want to misdiagnose an individual. So treatments when it comes to brief psychotic disorder. So there's pharmacological treatments for brief psychotic disorder. It may include medications such as Risperdal, and these medications help to reduce the intensity and the frequency of the psychotic symptoms. Now, our non-pharmacological interventions that have been shown effective for treating brief psychotic disorder, that includes cognitive behavior therapies. So we know with cognitive behavior therapy, that is going to have a focus on restructuring or changing those negative thoughts to improve a mood or behavioral functions, right? So this approach of cognitive behavioral therapy, it can help people manage their stress and it can also teach and introduce improved or better coping mechanisms. Another treatment modality that has been shown effective when treating brief psychotic disorder is going to be cognitive enhancement therapy. So the benefits of cognitive enhancement therapy is that people struggling with psychotic disorders, this therapeutic approach can help them improve their social and their vocational skills, because we know that within that 30-minute period time frame at least, right? They're exhibiting those bizarre behaviors. So let me help you transition back and learn these skills to improve. And then another proven therapy is going to be the acceptance and commitment therapy. So this strives to improve the psychological flexibility, and this can help those individuals experience psychosis and other related stress. All right, so how can we remember brief? So I literally, when I think of brief psychotic disorder, I focus in on the word brief. So if I take that down, like we have here, and the B in is going to represent brief, something that's very short, 1 day to 1 month. Okay. When we look at reality, this is going to be reality distortions. Those distortions include hallucinations. So you can have a visual hallucinations. An individual can say, I'm seeing certain objects, I'm seeing people, or maybe I'm seeing a light that's not present by other individuals. Hallucinations can also be something that is tactile. So this could be something that an individual feels as if like there's a bug crawling on their skin, or maybe they have auditory hallucinations where they're hearing sounds or hearing whispers that aren't really real. And many times when individuals experience auditory hallucination, it's going to be of that voice that's giving them a command or giving them an action or commenting on a behavior that they have exhibited. So the I in brief is going to be your identifiable trigger possible, right? So this can happen with or without that life stressing event. When we go back into that scenario, we know that life stressing event was going to be when the fiance unexpectedly broke up and just called it quits, right? So next, we want to make sure that we exclude any sort of medical, we exclude any substances. That is going to be important. And lastly, the F in brief is full recovery. So we know after these symptoms have resolved, they're going back to their previous level of functioning. So brief, literally, brief psychotic disorder. B is brief, reality, identifiable, exclusion, and full recovery. So I hope that this acronym helps whenever you're looking at a scenario and you're trying to differentiate, how do I diagnose this, right? Brief. Remember, does not exceed 30 days. That is going to be that number one key distinguisher factor. It's like, all right, this is very similar to schizophrenia, but that timeline, that duration says it does not exceed 1 month. Okay. All right. So, our next scenario here, we have John. So, this is a 22-year-old college student, is brought to a mental health clinic by his mother after displaying unusual behavior over the past 2 months. He has become increasingly withdrawn, skipping classes and avoiding friends. His mother reports that John often speaks to himself, seemingly in response to voices no one else can hear. So during the clinical interview, we notice John is disorganized in his speech, frequently jumping between unrelated topics. He appears anxious but denies any drugs or alcohol use. His grades have declined, but he still manages to attend some classes. And again, We know he has no history of previous psychiatric issues. Medical workout reveals no underlying physical conditions. So, as I read through this rationale, what were some of those key things that stuck out to you? What is important here so we can figure out how do we diagnose John? What's important? Age, timeline, hearing voices, 2 months. Yes. Avoiding social interaction. Absolutely. Absolutely. So we have this 22-year-old college student, right? He presented at this mental health clinic. Yes. His mother is like, hey, John is displaying unusual behavior. But how long has this unusual behavior gone on? Sarah let us know. Over the past 2 months, right? This is critical information. Now, y'all also picked out that John has become increasingly withdrawn. He's not even hanging out with his friends. He's like, you know what? I don't want to be bothered. I am avoiding any interaction. Now, something else that his mother noticed is that John is beginning to speak to himself, right? So we know that he is experiencing possibly auditory hallucinations, right? Because he's responding to voices that no one else can hear. Yes, Angela, observations by the mother. Absolutely, absolutely. Pam, no prior history. Very important. So during this clinical interview, we're meeting with John. We notice, okay, John is disorganized in his speech. He's jumping between topics. One moment he may be talking about sports, the other minute he's talking about dogs. And it's like, how is this connected, right? Where is the correlation here? We're jumping back and forth between unrelated topics. And as he's doing this, we notice his behavior, he's anxious, right? But when we're doing this clinical assessment with him, John's letting us know I don't have any history of drugs. I don't have any history of alcohol. I don't have any prior psychiatric issues. And I have no physical condition. So now I know I can rule that out. So, what would be the appropriate diagnosis for John? We know he has unusual behavior, he is withdrawn, he's not seeing his friends. Oh, y'all are on it. I love it. Absolutely. Schizophreniform. Y'all are on it. Awesome. What gave it away? What was that key thing where you're like, oh, yeah, that's schizophreniform? What was that, Sarah or Haley? 2 month timeline. Absolutely, right? Duration tells us so much. Yeah. 2 months in paranoia. Absolutely. All right, let me go on to the next slide here. Perfect. All right, so schizophreniform. So when I say schizophreniform, I really like to think of this diagnosis of like that trial period or the trial subscription because of the duration. So when we look at schizophreniform, this diagnosis does not exceed 6 months. If it does not exceed 6 months, I cannot say that individual has schizophrenia. Okay. Now, the characteristic symptoms of schizophreniform, they are completely identical to schizophrenia, right? But what is that key distinguisher? Why am I going to say, oh, it's not schizophrenia? It's schizophreniform. Why would I say that? Feel free to put the answer in the chat. Yes, duration. Absolutely. Less than 6 months. Y'all got it. I love it. Yes, yes. Right. So that key distinguishing factor is the duration, the total duration of the illness, right? 1 month, but less than 6 months. Okay. So the diagnosis of schizophreniform is made underneath two conditions. Okay. So, one, when an episode of the illness lasts between 1 to 6 months and the individual has already recovered. The second condition is when individuals are in that symptomatic is less than 6 months durations, and that's required for the diagnosis of schizophrenia, but has not yet recovered. So in this case, the diagnosis is going to be noted as schizophrenia form, okay? Because it's uncertain if that individual will recover from the disturbance within that 6 month period. Now, as a clinician, when we're doing this assessment on schizophrenia form, we want to make sure that we are paying attention to the cognition status, depression, any mania symptoms or those mania symptom domains, because it's vital for making critically important distinctions between schizophrenia spectrum or any other related psychotic disorders. When we look at schizophreniform, some of those early signs that we may see in individuals, it may include those feelings of anxiety, nervousness that kind of lingers on, the isolation, a decline in work or school performance, and excessive worrying or irritability. They're struggling to organize their thoughts. So those are kind of those early symptoms that we can pay attention for when we're considering a diagnosis of schizophreniform. So I did schizophreniform right here in red because this is a form, right? This is a form of schizophrenia. It's that short version, kind of like that trial period, that trial subscription, right? It's not, I don't want to have that full on commitment just yet. It's just short, okay? So, what causes this? So, I was reading through the DSM-5 last night, and it was just really interesting to me that like genetics have a play in the diagnosis of schizophrenia form. So this disorder tends to run in biological families. So while having a biological parent with this condition, it does increase the risk of developing it. However, it does not guarantee that you will have a diagnosis of schizophrenia form. It is just a consideration into the diagnosis, okay? And then something else too is the brain chemistry. So if you have schizophrenia or schizophrenia form, you may have a imbalance of those certain chemical messengers in your brain, like our neurotransmitters. So this imbalance in these chemicals, they can interfere with the transmission of messages, leading to those symptoms that have been right here, like our positive and our negative symptoms. Something else that I found really, really interesting is that the environment matters, right? Who would have thought environmental factors could have a weigh-in on the diagnosis of schizophrenia form? So evidence suggests that certain factors in the environment, it might trigger schizophrenia form, and people who have inherited like a tendency to develop this disorder, which is most likely caused by a highly stressful event. So I work at Department of Veteran Affairs, and during my time in the inpatient psychiatric unit, I would notice that a lot of times there will be a misdiagnosis between either schizophrenia, schizophrenia form, or PTSD, because those symptoms can mirror each other. And if we don't really complete that thorough, comprehensive assessment to get a sound understanding of everything that this individual has gone through, we may fall victim to having that misdiagnosis. So it's so important that we really pay attention to what symptoms are being presented. What is the duration? What is the frequency? Is this something that's abnormal, right? Let's get a full history of schizophrenia form so that way we can have that correct diagnosis. So, some therapeutic approaches that have been proven for schizophrenia form include psychotherapy, right? So, we know psychotherapy is talk therapy, right? So, when we have our talk therapy, this is going to help our clients identify and change those unhealthy emotions, those unhealthy thoughts, or behaviors. And when you're having or when you're implementing psychotherapy, you want to make sure that you establish goals, and you want to make sure that that client is able to manage those everyday difficulties that are related to the condition. So I'm going to quiz y'all. What is the duration of schizophrenia form? Yeah, absolutely. Does not exceed 6 months. Yeah, 1 to 6 months. Absolutely. Awesome job, everyone. Yes, 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 yes. 6 months. Beautiful. Now, if I were talking about brief psychotic disorder, what would be that duration? Under 1 month. Yes, Courtney. Yes, absolutely. Now, when we look at both of these diagnoses together, what is something that's common between both of them? It has something to do with the positive and negative symptoms. Yes, delusions, absolutely. What else can be present in both of these? Hallucinations, absolutely. Yes, yes. Hallucinations can be broad though, right? So, what kind of hallucinations? What are the different types? Yes, tactile, absolutely. Auditorial, visual, absolutely. Y'all are on it. Oh, I love it. Good, good, good. All right, let's go on to our next slide here. All right, so Maria, a 29-year-old woman, is brought to the hospital by her family after months of unusual behavior. She has become increasingly isolated, stopped attending work, and often mothers to herself. So Maria reports hearing voices that criticize her and tell her she's being watched. She believes her neighbors have installed cameras in her home to monitor her every move. During your clinical interview, Maria demonstrates disorganized speech. She's jumping from one topic to another without any clear connections. She shows little emotional expression and she's struggling to maintain focus. Maria's hygiene is poor. She lacks the motivation to complete her daily activities. Maria's symptoms, they've been persistent for over a year. So these symptoms have significantly impaired her social and occupational functioning. We did the medical workout, and that completely ruled out any substance use in this situation. So, who is our client and what is going on with her? What is important? What should we highlight here? Right, over a year. Absolutely. This is important because this lets us know the duration, right? So we're already setting the tone over a year. If it's over a year, can I diagnose brief psychotic disorder? Is that it? Is that the diagnosis? Is it brief psychotic? No, right. It's not. It's not. What else is so important? What else is going on with Maria? We got this 29-year-old woman here. Paranoia, absolutely. Absolutely. How is she paranoid, Christy? What's going on? Right? Social isolation. Absolutely. Yeah. Chrissy says she thinks her neighbors are watching her, right? So Maria, she has installed these cameras in her own home because she believes the neighbors installed the cameras in her home because she's like, they need to watch every move that I'm making, right? That is her belief. What else do we know about Maria? Is there any sort of hallucination going on with her? Yeah, poor hygiene. Absolutely. Absolutely. We know we're in this clinical interview. We know her hygiene is poor. She lacks the motivation to do any of her daily activities. So she's like, you know what? I am not interested in doing that. I just want to be here. I don't want to be bothered. I don't have an interest in it. Yeah, lack of expression. Absolutely. Absolutely. And we also know Maria is hearing voices, and these voices are criticizing her, and they are telling her, Maria, you're being watched. Yes, Christy, auditorial hallucinations. So let's break this down because we've highlighted some really good information here. So, and I want to make sure that we get the proper diagnosis. So, our client, Maria, she's 29. Her family brought her to the hospital because it's been months, right? It's been months of unusual behavior. We know Maria has isolated herself. We know Maria is hearing voices. These voices are criticizing her. They're like, hey, Maria, you're being watched. Your neighbors installed cameras in your home because they want to monitor every move that you're making. Something else that's important that we forgot to highlight during our clinical interview, Maria is exhibiting disorganized speech. She is jumping from one topic to another, again, without any clear correlation. How does this correlate? The kids say the math is not mathing, right? So, what's going on? And we know she has very little emotional expression. Her hygiene is poor. And this has been going on for over a year. So critical. Over a year. How would I diagnose Maria? We know we've ruled out brief psychotic disorder. Is this, yes, schizophrenia? You were on it. Yes. Absolutely. Good deal. And we know it's schizophrenia because of what? Why do we know this? Time. Absolutely. Yes. Duration. Absolutely. I'm telling y'all, duration, frequency, and symptoms is going to be your best friend when you're thinking about diagnosis. Definitely. All right. So let's learn a little bit more about schizophrenia. So the characteristics of schizophrenia, it involves a range of cognitive, behavioral, and emotional dysfunctions. And it's going to be a continuous of these signs and these disturbances that persist for at least 6 months. It can go on further, but we got to hit that 6 month mark, right? So individuals with schizophrenia, they may express a variety of unusual or odd beliefs that are not of necessarily a delusional proportion, like those ideas of reference or magical thinking, but they may have that unusual perceptual experience, sensing the presence or seeing people that are not really there. And we know we saw that with Maria here, right? She's hearing voices, they're criticizing her. They're like, hey, Maria, you're being watched. So when we think about schizophrenia too, their speech is generally understandable, but it can be vague. And their behavior may be like grossly disorganized. So they may be mumbling in public. So that's how you would know, like, okay, this is a grossly disorganized behavior. Now, individuals with schizophrenia, they may display an inappropriate affect, right? So these individuals, they imagine you're in a setting and maybe you're like in a serious educational learning setting and the presenter is discussing about the seriousness of diagnosing. And this individual may laugh, right? So that is a display of a inappropriate affect. This was not a societal normal laughing matter. So it's kind of like, okay, that's something that we want to take note of. So also, schizophrenia can have a dysphoric mood and it can take the form of depression. It can mimic anxiety. There can be anger. There could be a disturbed sleep pattern. Do y'all see how this can easily be confused with PTSD, right? It's so important that we pay attention to these symptoms and get a full comprehensive outlook on what is going on with this person because we have to make sure we have the correct diagnosis for them. So, a common myth that has been introduced when talking about schizophrenia is, have y'all ever heard that schizophrenia is more commonly diagnosed in men versus women? Have y'all ever heard that? No, maybe. Yeah, yeah. Okay. Good, good, good. I heard that too, Angela. I thought that was the truth. But as I was reading through the DSM-5, it made mention that there was a worldwide study, and that study found absolutely no difference between men and women when it came to the diagnosis of schizophrenia. I was like, wow, that is definitely something because I always thought men were more susceptible to get schizophrenia because that's what I was taught. But I'm here to tell you, according to the DSM-5 TR, there was a worldwide study and there was no difference found in between the sexes of a man and a woman. Now, the peak onset age, it can occur early in the mid 20s for men. And then for women, it can appear in the late 20s, in the late 30s. Now I'll tell y'all something else too that I found out that I was like, wow, that's really interesting. So there can be a late onset of the age of 40, right? So this is something that was introduced to me in the DSM-5 where individuals of 40 or later, they are overrepresented by women. And this population group that they did this study on was women that were married, right? So they're saying, hey, maybe you had a divorce, and because of the trigger, that traumatic experience, you could develop psychotic symptoms, which could relate to schizophrenia. Isn't that something? Like I was like, wow, that is definitely news to me. So the onset may be abrupt, it may be insidious, but the majority of individuals manifest like a slow and a gradual development of a variety of clinical significant signs and symptoms, particularly those that are going to appear as socially withdrawn. They're going to experience those emotional changes. They're going to have a shift or a transition in their cognitive abilities. And because of that shift, it's going to produce a significant decline in their role and functioning. So, just how we saw back in this scenario that Maria, she had that significant shift because she was like, you know what? I'm struggling to maintain focus. My hygiene is poor and I have absolutely no motivation to fulfill my daily activities. So, this is something that we really want to pay attention to. How is this individual behaving? All right. So, and I'm going to share a little bit of facts here. With schizophrenia, so the essential features of schizophrenia, it can be the same in childhood. However, it's more difficult to diagnose in children because hallucinations and delusions may be less elaborate than in adults. And visual hallucinations are more common and should be distinguished from normal fantasy play versus a kid using their imagination, right? And then also disorganized speech. So this occurs in disorders with children with childhood onset or on the autism spectrum, right? They may have disorganized behavior, ADHD. So these symptoms, looking at childhood, it could be attributed to a later on diagnosis of schizophrenia. So, some other things that I found out that I was just like, I never knew this as I was reading through the DSM-5 is that schizophrenia, they indicate that this disorder, it may be at risk for children that are growing up in urban environments. It may be for refugees, may be at a higher risk. It may be for those socially oppressed groups facing discrimination. So there's evidence that social adversity and your social economic factors may be associated with the increased rates of a diagnosis of schizophrenia. Did y'all know that? Is that something new? Am I just late? Let me know. Feel free to put in the chat. It's okay. So another thing with schizophrenia is that suicidal behavior is oftentimes a response. Okay, Angela, I thought I was alone there. That was definitely new to me. That was something that I was reading through and I was like, wow. I was unaware that because of your social economic environment, because you may be more inclined to oppression or discrimination, that those factors could be associated with a diagnosis of schizophrenia. So the correlation of schizophrenia and suicidal thoughts and behaviors. So, this is something that is very serious because suicidal behavior is sometimes in response to a command, one of those auditorial commands of hallucination, right? That command or that comment may say or may shed light to instances on how one can harm oneself. So suicide risk is going to remain high over an individual's entire lifespan when they are diagnosed with schizophrenia. And this is for men and for women, okay? There is no distinction when it comes to that. So it is so important that if you're seeing a client and you know they have that schizophrenia diagnosis, that we are completing that Columbia Suicide Screening Assessment, and we are really making sure that if there was a previous history, what's going on? Are we able to identify those triggers? And we want to make sure that we follow up with that client because even though we discharge them, say we're in an inpatient unit, even though we discharge them, we have to do our due diligence and we have to follow up because suicidal behavior is such a large correlation to those individuals diagnosed with schizophrenia because of auditory hallucinations, having those commands, okay? So, other risk factors, they include those symptoms of depression, maybe feeling hopelessness, being unemployed, right? And then another risk factor is going to be that period after a psychotic episode or that hospital discharge, right? So the number of psychiatric admissions is the closeness to the onset of the illness in older age could be a significant risk factor, okay? All right, so I have a quiz up here for you all. So feel free to put your answer. You can type it all out or you can just put the letter. But which of the following best describes the onset of brief psychotic disorder? So this question is asking me, do I know the onset of brief psychotic disorder? Ooh, y'all are on it. Absolutely. Yes, yes, yes. What what is the number? What is that quantitative number that I'm looking for? Who knows that? What can it not exceed? You got it, Sarah. 30 days, right? Less than 30 days. 1 month. Absolutely. Wonderful, wonderful. Okay. All right. So I have another question. I have another one because y'all did so well, right? So, what criteria must be met to rule out other causes of psychotic symptoms? So, I'm looking for a specific criteria that has to be ruled out for psychotic symptoms. Yes, all of the above, right? We have to make sure that we rule out substance use. We got to rule out medical, and there cannot be another psychiatric disorder diagnosis that is into play. Have to rule all of that out. Absolutely. Awesome. Good, good, good. All right, so let's go on here. So we have Alan. Alan is a 35-year-old software developer is referred to therapy by his employer after concerned about his social withdrawal. So Alan has no close friends. He avoids social events. He prefers working alone. He described himself as being indifferent to relationships, including family members. He spends most of his free time engaging in solitary activities. He likes reading, playing video games, and he has very little interest in a romantic relationship. So during your clinical review interview with Alan, he speaks in a very monotone voice, shows minimal emotional expression, and we know he has no history of hallucinations or delusions. And he's like, I don't feel sad. I'm not anxious. I just don't see the point in socializing. And I want to be alone. I feel comfortable being alone. So let's go back into this. What is so important when we think about a diagnosis for Alan? What should I highlight? Who is our focus? What's his name? Right? His age, 35? Absolutely. That's a good point. Good job, Rebecca. Yes, Alan. So Alan is a 35-year-old. He's a software developer. That's cool, right? So, but he was referred to us because of what? Why is he coming to see you or us? Right. He's been referred because his employer is concerned about his social withdrawal. So we know with Alan, he doesn't have any close friends. He's avoiding social events. And Alan is like, just leave me alone, right? I want to be alone. He's saying, I'm indifferent to having any sort of relationship. It doesn't matter if you're my brother, my sister, my mother. It does not matter if you're family. I'm just very indifferent to having or building or cultivating a relationship, right? Alan likes to spend a lot of his time doing solitary activities. This is important. So we know he likes to read, he likes to play video games. Okay. And then we also know Alan, he's not interested in a romantic relationship. How does Alan present during his clinical interview? What is his behavior like? Monotone. Absolutely. Absolutely. Monotone voice. What else is going on? If I'm doing my mental status exam, what am I noting? Minimal emotions. Absolutely. Monotone voice, minimal emotional expression. What else is critical? What else do we need to know about Alan? I'll give you a hint. It's down here in this last part here. What else should we highlight when we are trying to look at Alan? It's gonna be Alan has no history of hallucinations or delusions, right? We can rule that out. And because he doesn't have a history of hallucinations or delusions, and he's also indicating to us, I don't feel sad or anxious, right? So let's break this down into something a little bit more simpler. So our client here is Alan. He's 35 years old. He got referred to us because his employer was concerned that he is socially withdrawn. We know Alan doesn't have any close friends. He doesn't want to go hang out with anyone after work. He's avoiding those social events because he likes to be alone. He's letting us know, I really just don't have an interest in cultivating relationships with family members. I really just want to be by myself, enjoy my solitary activities. I want to play my game. I want to read my book. I don't want any interruptions, right? Something else that's critical here when I look at Alan is I know Alan doesn't have a history of hallucinations or delusions. So because of he doesn't have a history of hallucinations or delusions, can I diagnose him as schizophrenia? Can I rule that out? Yeah, absolutely. I can rule that out. Good deal. Yes. So I'm ruling out schizophrenia. So is this brief psychotic disorder then? No, it's not. It's not. Right? And I'll tell you another thing. Do we have any sort of duration that's being presented to us in this scenario? No, we don't, right? All we have is behaviors and symptoms. So, primarily, if you could sum this up in one word, or maybe a couple of words, compare, what would you say Alan is like? How would you describe his behavior? Absolutely. Schizoid personality disorder. So Alan meets that criteria because he has that pervasive detachment from solitary activities. He has that lack of interest in intimacy, and he has restricted emotional expression. So an appropriate therapeutic approach that would help Alan is we want to make sure that that focus has a insight on building and cultivating his behaviors and exploring alternative ways to improve his workplace interactions. Absolutely. Good job. So, schizoid personality disorder. Whenever I hear schizoid, immediately my mind goes to an individual who's a loner. Okay. So, individuals with this personality disorder, because it's a personality, it's part of cluster A, they appear to have a lack of desire for intimacy. They seem indifferent to opportunities to develop those close relationships, and they do not have like a derived satisfaction from being a part of a family or any other social support group, right? So, schizoid, this is that definition of like, you know what? I am completely unbothered, right? Like, I don't care if y'all are going out to enjoy lunch. I am going to enjoy my solidarity and I'm going to be unbothered and I'm going to be at peace because that's what makes me happy, having my lonesome, right? So they have these characteristics of really seeming indifferent to the approval or of criticism of others, and they do not appear to be bothered by what other people may think about them. They're like, okay, you think that about me? Cool. All right. Doesn't phase me, right? It doesn't have a any indifference to it. So oftentimes individuals with this personality disorder diagnosis, they live their lives somewhat directionless, and they may appear to kind of like just drift into their goals because there is no strong motivation behind it. It's just like, all right, I'm just going with the flow, right? Taking it one day at a time, but I'm completely unbothered by it. So how can I remember schizoid personality disorder, right? So I say schizoid. When you verbally say it out loud, you're going to say schizoid, but then it could be schizoid, right? Schizoid. So this is kind of a little neat way that in my mind, I was able to remember this. So schizo, we know this is that disconnection from those social relationships, right? Void. If you're avoidant or you're avoiding something, you have a lack of interest in doing those social interactions. You do not want to be connected to it. So you have that void. So schizoid, schizoid. I really hope that helps y'all. All right. All right. So my next one here. Sophia. So Sophia is a 27-year-old freelance artist. She's been referred to therapy by her family to her unusual behavior and difficulty maintaining relationships. Sophia often talks about having a sixth sense, and this allows her to predict future events and claim she can feel other people's emotions from a distance. Sophia dresses in a eccentric manner. She's wearing mismatched clothing and several amulets because she believes she has protective powers. So, we're doing this clinical interview with Sophia, and today she's speaking very vague in a tangential manner. She's often veering into metaphysical topics that are difficult to follow. She reports feeling anxious in social situations because she believes others are judging her thoughts or energy. Despite her isolation, she expresses a desire for connection, but she struggles due to her odd behaviors and beliefs. So, what is so important about Sophia? What is going to help us kind of come to a diagnosis of her? What should we highlight? Who's our client? What's her name? And how old is she? Absolutely, Christy. So we have Sophia, 27-year-old. Absolutely. She came to therapy because her family is like, hey, she has this unusual behavior. Rebecca says she is all over the place. All right, so she came to us therapy because her family's like, hey, Sophia has unusual behavior. She has difficulty maintaining relationships. What does Sophia believe that she has? Yeah, special powers, right? Sophia says, I got a sixth sense, and this sixth sense helps me predict future events, and I can feel the emotions from others in the distance. She has this special power that allows her to do that, right? And y'all already indicated she dresses in a very odd, eccentric manner. She has on mismatched clothing, right? So you're doing your clinical assessment with Sophia. How is she presenting? What behaviors would you note? What am I going to highlight during her clinical interview? What is her speech pattern like? Yes, speech is vague, tangential speaking, right? Absolutely. So she's just tangential. She's all over the place, right? Like things are not correlating, they're not connecting. Sophia, what is going on? Rebecca said it. She's all over the place, right? So she's talking about these metaphysical topics. We're like, I'm not following. What's going on, right? Another thing that's important in this situation is Sophia is anxious. And she's anxious because social situations, she feels as if others are judging her thoughts. They're judging her thoughts, right? So they're judging her thoughts and her energy. Now, even though Sophia is isolated, she's like, you know what? I really want a connection. I want to be able to have like that romantic relationship. But because her behaviors are so odd and her beliefs are odd, she does not have that, right? So we got this 27-year-old. She has this unusual behavior. She has difficulty maintaining relationships because her behaviors and her beliefs are odd. She wears mismatched clothing. She has a tangential speech pattern where she's talking about metaphysical topics. And then she believes, hey, other people are judging my thoughts and my energy. What diagnosis would we give Sophia? Schizoaffective. That's a good one. That's a good one. The only reason, Rebecca, that it wouldn't be schizoaffective, we don't really focus in on too much on her mood. And that's going to be critical when we diagnose schizoaffective. Kari says schizotypo. Absolutely. Yes, 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 yes. So Sophia meets the criteria for schizotypal personality disorder because of her pervasive pattern of those social interpersonal deficits, her beliefs in eccentric behavior and eccentric thinking patterns, and she has a discomfort of close relationships, right? We know she has difficulty maintaining these relationships. So the therapy that would be beneficial to her is we want to make sure that we can improve her social skills and we can address her distorted thinking patterns. So this is going to be schizotypo. Wonderful job. So with schizotypal, the essential feature of this is going to be that pervasive pattern of social and interpersonal deficits marked by acute discomfort or a reduced capacity for close relationships, as well as like that cognitive or perceptual distortions. And something that's I found neat when I was reading through the DSM is that this pattern, it can begin in your early adulthood and it presents in a variety of different contexts. So, schizotypal personality disorder, it may first be apparent in like those childhood or adolescent experience where you notice that maybe this adolescent has solitary, like they just really enjoy playing by themselves. They may have those poor peer relationships. They're not really eager to say, hey, can my friend come over? Or I want to go over my friends. They're not really worried about connecting with others. Okay. And then another key distinguisher when we think about schizotypal is they have that social anxiety. And oftentimes there's an underachievement in school and a hypersensitivity to like those peculiar thoughts and languages and bizarre fantasies. We know Sophia had the bizarre fantasies because she's like, I got these special powers, right? So that's something that we can consider. And then even though that these symptoms may present in childhood, it can present and continue on into your adulthood. So this is something that schizotypal individuals, they often are considered to be odd, eccentric, because of their unusual mannerisms or their unkept manner of dress, that their clothes may not match. Maybe it doesn't fit together. It's like you have on a bubble coat, but then you have on shorts and maybe boots. And it's like, okay, that what's going on, right? Like it's an odd way of dressing. It's not necessarily the normal attire. So schizotypal, that really distinguishes that factor of schizoid, right? Schizoid, is that these individuals, they want and they desire to have interpersonal relationships, but because of their behavior, it causes challenges, right? So their behavior suggests that they really want to decrease desire for intimate contact, but in reality, they really want to have that connection, okay? So imagine that like you're at a birthday dinner and the individual with schizotypal, often they may first get there, they may be relaxed, but as time goes on, they may increasingly become tense or they may become suspicious of others. So when it comes, I'm going to ask y'all a question. When it comes to relationships, which disorder between schizoid or schizotypal wants or has a desire to connect with others? Is that schizotypal or is that schizoid? Yes, schizotypal, absolutely, absolutely. Because we know in our schizoid, right? They're voidant. They do not want to connect with others. They have a zero desire to engage in those social interactions. Whereas an individual with schizotypal, they want that desire, right? It's just because of their odd thinking and their odd speech that their behaviors lead others to think otherwise. Absolutely. Good deal. All right, all right. So that is the end of my presentation. Definitely want to give y'all a shout out for the awesome participation and engagement. Y'all have made this definitely an enjoyable experience. And if y'all have any questions for me, please feel free to come off mic or put it in the chat. Y'all are welcome. Absolutely welcome, welcome. I hope that this information is helpful for you all, and hopefully, I gave you all some different tricks to have just like that foundational knowledge of the schizophrenia spectrum. Y'all are welcome. Yes, good, good. I'm glad it was helpful. So, if you're just, I'm just asking this off top of my head. Out of these diagnoses that we reviewed, which one are you like, oh, I want to know more about this diagnosis? Which one really intrigues you? Or is it all of them? Schizotypal? Yes, 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 yes. Absolutely. Good deal. All of them, right? It's kind of like, man, let me go get this DSM-5. Let me pull it out and let me read. Yes, yes, yes. Oh man, y'all have been great. Absolutely. All right. Any questions for me?
Well, Jalen, we really appreciate this presentation. This was an awesome presentation, and you covered so much. I love the style of the way that you covered each section, because like you said, in the small amount of time that we had, it's difficult to just really go into details that will stick. And I think that the way that you presented it in a way for me to be refreshed and to learn some things that were new and to have them to really stick. One of the things that stood out for me was the I like the schizo void or schizo void. So I'm gonna remember that one. I gotta use that one. I'll give you credit. Because I'm saying, hey, that's where I got it from. I gotta use that as
Right?
vision
It's
too.
like they're voidant, so they think of loners. Schizoid, right?
Yeah. Yeah.
Little
Avoiding.
play on words. Yes.
Yes, yes. And then it seemed like not the opposite, but when you get to the schizo tip typo, or I sometimes mix up the pronunciation, schizotype, they actually desire relationships, but have some pretty unique presentations with I think we get some pretty unique presentations with all the schizos. And so I haven't gone to a training to where uh, all of this was clustered together with the schizos, and so I'm really fascinated to learn myself even though I'm hosting the training. Um, So I appreciate that. But yeah, we are at the end of the training for today. I really appreciate you all who have joined this training. If you have any questions about the training or anything, I want to encourage you uh, to email us. And let me get the email because we want you to be able to contact us. You should be able to, you will be getting your continuing education units. We're hoping to have that within the next couple of days. Uh, but certainly, if you don't get that right away, you know, the end of the week latest. But we've been really good to kick these out, and it's not a huge group, so we should be able to get that out. Spread the word about the training. We invite you to do that if you enjoyed it. Um, but we want to email support. That's support at aspirecounselingal.com. Support at aspirecounselingal.com. And there you can definitely uh, get in contact with us if you have any issues with your training or receiving your continuing education units. But we're going to go on and close out for here for now. And we thank you all again, once again, for attending. We hope that you had an enjoyable experience. And yes, this is the training you need for those of us that are in Alabama to get that DSM check off. And we appreciate you attending. Again, if you have any questions about anything, don't hesitate to email me or reach out to me about any questions or concerns that you have. But until next time, we will see you soon. And you all have a blessed and safe rest of the evening and take care. All right. Thank you all so much.